This is Dr. Sandra Kramers, and I'm going to talk to you today about glaucoma so you can understand what glaucoma is. Here is an example of the eye. This is the right eye. The surface of the eye is called the cornea, and inside the cornea, we'll say, is the colored part of your eye called the iris. And if we do a cross section, you'll see that behind the iris is the lens. And then behind the lens are these little processes called the ciliary processes that we believe produce, or does produce, the liquid inside the eye. The liquid, or the aqueous fluid that it produces, has to go around the lens, through the pupil, and then it drains. If I take off the cornea, you'll see it drains in the trabecular meshwork, which is a little cul-de-sac or a little pocket that goes all the way around 360 degrees, that drains out of the eye. That's called the aqueous humor, and it goes through the trabecular meshwork. So what can happen sometimes, you've heard in some of my other videos, something called narrow angle, where the location between the iris and the drain is narrow. So this is the colored part of the eye, and the drain becomes very narrow. So it's called an angle because it actually does look like an angle. The angles usually looks about 45 degrees, and it can get very narrow. If that happens, it can cause the pressure in the eye, because there's no ability for the liquid to drain, to increase. If that pressure increases or decreases and it increases, it can damage the cable that connects the eye to the brain. This is called the optic nerve. The optic nerve is the only place in the body you can see a nerve without cutting open the body or the skin. So it's beautiful. You can see the nerve by looking right through the pupil. We can also see the nerve die. And the way you see a nerve die is through time. You can see the color change and the way it actually looks in terms of the actual cells by looking with a microscope in the eye. So glaucoma, by definition, is damage to the optic nerve, leading to visual loss. And so we have many tests now to see if that's developing. It's usually tested through time. Sometimes we'll look at a nerve and it looks like there's some type of abnormality, but the tests over time are normal. And we call that physiologic cupping, meaning that the nerve genetically has a inner opening that's large, but it's actually not malfunctioning, it's not dying. If somebody starts to have high pressure in the eye, we have many treatments to decrease it, because that's one of the key ways to prevent strangulation of the nerve, glaucoma loss or glaucoma. And so I'm going to go through that with you. So just to recap, this is the cornea. Behind the cornea is the iris. Behind the iris is the lens, which we talk about in the cataract surgery video, and I'll just briefly mention the lens is like a pillow in an enclosed pillowcase. You have the top part of the lens called the anterior capsule. Inside is the nucleus, like the pillow, and then the back part of the lens is called the posterior capsule. Behind the lens, or around the lens, I should say, is the ciliary processes, which produce the aqueous. This is the retina, which is basically the kind of film of your camera that takes the pictures for you. The inside the vitreous is the vitreous. Inside the back of the eye is called the vitreous, which is a gel, kind of like a jello. And then you have blood vessels that go along the retina, and all that leads to the cable that is called the optic nerve, which connects to your brain and occipital cortex. So that's the eyeball. And then in terms of glaucoma, how we treat it is the following. And this is also on my blog. So the first thing I tell patients is obviously avoid risk factors for glaucoma, such as smoking. Don't be around smokers. Avoid smoking like the plague. You've heard me say this. Have a good diet that's low carb. Don't get diabetes, for instance, because diabetes increases your risk of glaucoma. Direct trauma to the eye can cause glaucoma, so eye protection when you're playing sports. And so this is basically those key things. If you have headaches and you're on Topamax, make sure you see an eye doctor, because that can cause acute angle closure glaucoma. I've seen many cases of that. And if you have headaches and you're not sure why, I always have patients see their eye doctor to get something called a pentacam, which tests for narrow angle with a picture test, which is great. So let's say we find that you have high pressures or you're developing glaucoma. The first tier of treatment is called eye drops, which is basically a drop you put in your eye, usually at nighttime, sometimes 2 or 3 times a day, and there's different tiers of eye drops. We know that the best type for most patients are called prostaglandin analogs, and so the brand names are called Lumagan, Zalatan, Travatan. The generic names are latanoprost and I'll try to remember the rest of those as well, but those work very well. They're usually once at nighttime. The downsides of those are redness or itching of the eyelids. And so we'll usually have patients put it in the refrigerator. You put the drop in, you put pressure in the corner right there, right? We do punctal occlusion, so the drop stays in the eye longer. And that keeps you close your eye after you put the drop in, it prevents the drop from going into the nose. So we call that punctal occlusion. And that also prevents you from tasting some of these drops. The second line is usually I'll use Alphagan, which is 2 to 3 times a day. Alphagan also works great, but it can cause more redness and burning than the first tier. That's why I use it as a second tier. But we know that the first tier, the prostaglandin analog, sometimes can cause swelling of the macula after surgery, like a laser surgery or cataract surgery. So we'll sometimes switch to an Alphagan and then go back to the Lumigan or Travatan or Zalatan or latanoprost if needed. The third line are the ones that have more side effects in terms of drops. So those are basically the Trusopt or Timoptic. Timoptic is a beta blocker. Timolol is the other name, the generic name, and that can sometimes cause difficulty with asthma. It can mask hypoglycemia in diabetic patients. It can sometimes cause tachycardia or heart beating fast. So we prefer to use the Timoptic as a last resort. It can even cause depression and impotence in some people. So if you have any of those symptoms, we try to obviously not take you off of those. And Trusopt can also cause more burning and just you can taste the drop a little bit more. So that's a third line. And then combination drops, sometimes one drop's not enough, so we combine them together, and there's different variations. Then, if the drops are not enough, we try laser surgery. And laser surgery is trying to usually make holes, is what we usually do. If you have narrow angle, we make a hole. I'll show you here. If you have narrow angle, we're making a hole, a microscopic hole in the iris, a very small one. So the fluid that's produced here can more easily get into the drain by taking a shortcut through the hole. So it opens the angle that way. If you don't have narrow angle, but you have no effect with the drops, we'll do what's called a argon laser trabecularplasty, or preferably a selective laser trabecularplasty, that's abbreviated SLT. And what that is with a contact lens we put on the surface of the eye, and the laser is directed at the drain that I mentioned, the trabecular meshwork that goes 360 degrees around. It's like a sink. Then we basically just literally knock some holes in the sink with the laser. The selective laser trabecularplasty can be repeated many times because it doesn't leave residual scar tissue to the other cells. So it just leaves a hole, and the hole sometimes will close and we just redo it. And so sometimes we'll repeat it multiple times. If the laser does not work enough, then we do what's called an eye stent. And we usually will do that at the time of cataract surgery. An eye stent is a little apparatus. I'll show you what it looks like. It's the smallest implant in the world. It's about 1 millimeter, and it's located right here. Can you guys see that? Yes, can I see that? And so we put that literally into the trabecular meshwork. There's a snorkel, a little opening where the fluid will go in, and then it goes right directly into the drain that takes the fluid outside of the eye. So that's called an eye stent. It works very, very well in most patients. Sometimes we'll put in even 2 if we're concerned one won't work. And we usually do that at the time of cataract surgery. If some patients also will do something called a goniotomy, which is basically we take a special instrument and we will go into the drain and cut it open to create a bigger opening, like your sink. We'll literally open up the whole sink or part of the sink to kind of let the fluid drain. So that works also very well. In some patients, that's still not enough, and then we'll do other types of procedures, such as an ECP or endoscopic photocyclocoagulation, which basically we use a fiber optic cable to apply more intense heat at the ciliary body, which is located behind the lens. And if that doesn't work, then we usually will try a trabeculectomy or Trabeculectomy means that we basically are making a direct hole between the outside of the eye and the inside of the eye, and we cover it with a clear covering of the conjunctiva that's on the surface of the white part of the eye, and that is the standard for glaucoma surgery. The downside of trabeculectomy is that it's a more involved surgery. There are risks because there is a hole, a connection between the inside and the outside of the eye, so there's a more risk of infection. But some people do need that. But we try to use a stent or lasers to avoid that if possible. And if the trabeculectomy does not work, or somebody has chronic uveitis, which means inflammation in the eye, we'll put a tube, so a glaucoma drainage implant, which is like a Barvelt or a Maltino tube, which is literally a tube that goes from the inside to the outside of the eye with a little kind of plastic plate that allows the fluid to drain out of the eye and then dissipate to decrease the pressure. So those are all the treatments in the world for glaucoma to date. If you have any questions, let me know. Everything is on my blog. Thank you.